if you have anything as well. All right, well, welcome back to our discussion on NAS, NOWS, and newborn care and supporting families who are at risk for or experiencing SED and OED during the perinatal period. And I'm starting this one just a little bit differently today. Normally, we've been starting with the cultural stories and Anishinaabe perspectives on the various stages of life. But this time, I'm going to do it um, a little bit differently. So, we're going to go into more of the clinical piece and get into what NAS and NOWS is and some of the supports that can be provided by the different types of providers who are providing wraparound care to a family, and with an emphasis, as always, on what Indigenous birth workers and supportive birth workers to Indigenous families can do to support families with those cultural pieces and with the early parenting skills. So that's going to be the focus for today. And Connie at the ITC always reminds us about respectful and compassionate language. And I wanted to start there with this presentation because I felt one is just a good reminder, but two, because we're talking about newborn babies and the language that can sometimes be used to describe what families are going through can seem like it's not compassionate or can seem very stigmatizing. And it can feel like it's actually really inappropriate to use certain words and phrases to talk about a newborn baby for a few different reasons. One, because we have that cultural reverence for our newborn babies and we want to have a shared understanding of the importance and the sacredness of them, but also because certain language doesn't apply to a newborn baby. So let's all get on the same page here. OUD is for opiate use disorder. So we'll kind of see SUD for substance use disorder and then OUD for opiate use disorder um, throughout the presentation. And that's just so I don't have to type it out every single time. It is helpful when we're talking about uh, any kind of substance exposure in the perinatal period that we're specific on what that could be. Not necessarily when we're engaging with families face to face as doulas, but because language does matter and the type of experience that a family could anticipate does depend on the severity of their substance use disorder. It depends on how engaged they are in a long-term recovery, if they're in medicated assisted treatment plan, if it's illicit street drugs that they're accessing. All of that actually does matter in the definitions of NAS and NOWS. And it can also have implications for what types of symptoms and treatments a newborn is going to need to access in that time. And so rather than using words like addicted, we're going to use ongoing substance use, long-term recovery, and rather than saying a baby is born addicted, I hear this all the time and it always drives me nuts because there is the behavioral piece of that an infant is not capable of. So, like a newborn baby is not addicted to substances. They are exposed to substances in utero and they could experience chemical dependence as a fetus. And then when they are born, they can experience withdrawal symptoms and they're having a special medical need surrounding that experience. But an infant isn't capable of like skipping school or like ruining relationships, like how um, people with ongoing substance use engage with the behaviors to support that. Infants are not capable of doing that. So we don't want to use words like this baby was born addicted or they were born addicted to opiates because that isn't compassionate. It also isn't accurate to the experience of a newborn baby. It also is just really stigmatizing to the gestational parent of the baby because Already there's just a lot of guilt, there's a lot of shame, there's a lot of stigmatization to that experience. We don't want our language and approaches to working with families to be a barrier for them to receive the care that they want. As we know, stigma itself is a barrier for people receiving treatment services. And we want to be really compassionate and caring and accurate in our language so that we're not like scaring somebody off and making them feel like they're too ashamed to receive care, or that they will hide their substance use or any type of substance exposures. And then, that's just going to lead to a lot worse outcomes for the family and more involvement with potentially with law enforcement. It's just going to be a mess for them. So the better we can get at using language that is person centered, that is compassionate and accurately describes what they're going through, the better chance our families will have when they engage with us. So I wanted to put that in there just to give um, like a ground level foundation for us to work from. And also because I am someone who's not in long term recovery and I haven't gone through the experience of having substance use disorder or opiate use disorder. Using the word addict isn't something that's authentic to me. I couldn't purport to speak from that perspective. I know that is a term that within the recovery community is meaningful and is an identity marker that someone could choose to use. But I make the choice not to use it because I don't have the perspective and it doesn't feel compassionate or authentic for me to use that term. So I'll use OUD and SUD, and I'm talking about families who are in treatment programs or treatment assistant. Then we're going to talk about substance use or substance exposures. And NAS is a broader umbrella term, and NOWS is more specific to opiates. So NOWS or NOWS is neonatal opiate withdrawal syndrome. And NAS is neonatal abstinence syndrome. So NAS is like the broad umbrella term that includes NOWS. NOWS is more specific to opiate use. NAS could include NOWS, but it could also include other substances. And in the clinical terminology, they would call it polysubstance exposure or polysubstance use, meaning there could be other substances that the fetus was exposed to in utero. And so the symptoms and experience of that infant would be a little bit different than what I'm going to focus on for this discussion, which is now specifically. Sometimes the terms are kind of used interchangeably, or NAS is almost like the universal term that I hear a lot of people using. But I'm seeing clinically that providers are turning more toward the term NOWS to describe a substance use disorder that includes opiate use disorder specifically, and can also apply to a fetus that's been exposed to prescribed opiates in a Medicaid assisted treatment plan. So it's not specific to illicit substance use in the perinatal period. And I'm not a nurse, I'm not a clinician of any type. So if there's any corrections to be made, I apologize for that ahead of time. And you guys can add those into the chat because I know there are some nurses and clinicians in here. If you have some additional resources on that, please do so. There's definitely a plethora of webinars and reading material that you can access to talk about those different the differences between them, as well as some of the more clinical pieces where we're going to get more into the support and the cultural side. So I'm appreciative of your compassion there. So, overview of this problem within our community. As we know, across the nation, across the whole US, there has been a massive increase in opiate use disorders for so many different reasons. And we know that there's a lot of intersections and a lot of inequities that are faced by communities that are specifically rural in their geographic location, that have a lower socioeconomic status, and within racial groups such as Native American or Indigenous people. And here in Michigan, what do we have? We have the perfect triangle of all of those three things. In a lot of our communities, we're facing socioeconomic hardships. We have high numbers of American Indians, and a lot of our communities are geographically rural, meaning isolated and sometimes hours away from those bigger city centers. And this is just a super gentle, and it's kind of tongue in cheek, but it isn't really that women are people. And so if we're seeing the rates of something go up in our culture, women are just people and we can get pregnant. And so we're just part of the population that can be impacted by health disparities. So um, there is this like additional stigma and like looking glass on pregnant women for their behaviors and for the outcomes that they go through. But really, they're just people. And so, if the rates of something are skyrocketing across the nation, of course, we're going to see it skyrocketing within the pregnant population because they're impacted by the same factors, if not more factors, than just the population in general and those who cannot attain a pregnancy. And so NOWS has also been increased just because the rates of OUD have increased across the nation. And as we know, in a lot of communities, both nationwide, and if we were to get real specific with it here in our community, there are deficits in access to MAT programs. And tribal communities have really been in the forefront of thinking about how to address those inequities and what creative ways tribal communities can bring resources to pregnant people in need. But there's still a need. And it's really a privilege to have MAT in a community. And I know there's a lot of hard work to be acknowledged that's gone into assuring those resources are accessible for tribal communities here. And we're still fighting a lot of stigma and misinformation about if pregnant people even deserve to have medicated assisted treatment. There's still a lot of misinformation as to the safety and efficacy of those programs. And so we still have providers in our communities who are working with people who need to access care who aren't sure if it's appropriate for a pregnancy. And that can create a snowball effect where a family feels like reaching out for help is like a dead end, even if they are brave enough to do so. The question is, how easy is it for somebody with an OUD to access treatment while they're pregnant or before they become pregnant? So that they can have healthier outcomes. Because what we know is that MAT is an evidence based program and does lead to better outcomes for a pregnant individual and their infant and the community as a whole. But we're still fighting the fight to get providers on board, and we're still fighting to get access for equitable access for all of the pregnant people in our communities who need that support. So now symptoms. I wanted to take some time to go through these because as people who work with families, when we support families, we provide that anticipatory guidance, meaning we're helping families to know what it is that they can expect when they go into a certain experience to reduce the fear and stigmatization of that experience. And knowledge is power. A lot of times when it's perinatal education, knowledge really is very powerful for families to have. And you can read about the symptoms, but seeing them and hearing them and having some guidance as to what to expect can be very different. And I've seen this happen in real time. So now symptoms for the infant at birth, and sometimes it can take a couple hours. So sometimes a baby will be born and they're not showing severity of these symptoms right away. And a family be like, oh, we're good to go. Like we don't have these symptoms, but they're going to be observed for a longer period of time than like a newborn counterpart that doesn't have an opiate exposure in utero, because some of these symptoms can show up at 24 hours of birth and they can last for a couple of weeks. And the severity of them will determine how long of a hospital stay and what kind of treatment supports a family is going to need to access. So a baby with NOWS could have frequent yawning and sneezing. And one of the most common signs and symptoms that can be disconcerting for the parents are the tremors, shaking, and seizures. Now, when you read this, and me in my autistic brain, and I see shaking, I just think like a kid who stayed out in the cold, because I take things literally, and some of you probably do too. Like, and they're like shivering. This isn't that. It's not enough to describe to just say that the baby is shaking. The tremors that they're having and the shaking that they're undergoing is like they're having a seizure and they're doing it constantly. So it can be very scary for a family who read or heard that their baby will be shaky to see their baby like literally constantly doing this, like they're having a seizure. It can be very scary because they could actually think that their baby is dying or that there's something seriously wrong with them. But it is the nervous system reaction to an opiate exposure. And there are treatments for that. So it's helpful for a family to know that the severity of that can vary from infant to infant and that it is treatable and it's not like a life-threatening thing that's happening. But it can be very, very scary when it's happening in real time and a family is seeing their baby. It's not like a shivering. It's like an actual like they're really, really shaking. They have an irritable, high-pitched cry. I've always thought about putting it in here, but I know some people are really sensitive to sounds. But if you could imagine how, uh, what's the word I'm looking for? Like, I don't want to say triggering because it's a baby and we want to be thinking about the language we use, but activating the way that the sound of a baby activates certain parts of our brain that are designed to respond to this needy little thing that we're responsible for. And then like take it up like a notch or two because the cry is so high pitched and it can be like nonstop. And in fact, one of the screening factors for these infants is how long it goes on and if it's able to be soothed within like a certain amount of time. That can be really challenging for a new parent who is already shaky from birth and is already on edge and high alert because they're already known to have a substance use disorder or some kind of exposure in their pregnancy, and they're real protective of this new baby and they want to succeed. Most families in this kind of a setting really want to do right by their babies, and so it can be really challenging to hear, like it is literally like this sensory experience of hearing this extremely high pitched cry that goes on for a long time. So some of the accommodation that could be made are the skills to support an infant through that experience, some of the treatments that are supportive for them, but also just any kind of accommodation that the parent needs to make to be able to bring down that level of activation, especially for people like me or neurodivergent who have like real high sensory issues already to begin with. That could be something that puts them like straight up into fight or flight mode. And we want to like be able to, without judgment, just bring them back to a place where they can really engage with and care for their baby, without feeling like this is like they're being threatened. So, earplugs, headphones, I wouldn't judge anybody at all if I saw them with noise blocking headphones on and if they're still able to be present with their baby and access those early parenting skills. That's the accommodation that's going to work for them. Also, there are ways to support an infant while they're going through this transitional time to bring down the amount of irritation and sensory overload that they can experience, which means in their actual room, we can turn down the lights, we can turn down any sort of sounds, ensuring that there are not as many temperature changes happening. All of that's going to be pretty well controlled within the hospital environment. So that is one benefit to being there because it can often be just really sensitive to the environment around them. They can have difficulty settling into sleep and staying asleep. So again, it's the experience of the baby that very much determines the mental health and capacity of the parents. Because if you think about the newborn period, and we're already going through so many changes within the body and mind of the birthing person, now the postpartum person, and then we're adding in the interruptions of being in the hospital. I think we all have seen the statistic that someone within 24 hours could be interrupted like 80 times or something. It's like a crazy amount of times how many times someone's coming in the door to disrupt someone's sleep. And then we add on an infant who's not settling into sleep and who doesn't stay asleep. As you can imagine, that can be really activating for somebody as well, who's already like on edge and already healing from giving birth. So that's something that we can support families with. Um, Muscle tone and stiffness. You will see babies that when they have now symptoms, they're literally like this. And you can't it takes a little more effort to like get them into swaddle position, or when you hold them, they're like they just feel really stiff. And again, that can be so scary for a family if they're not expecting it. So it's just normalizing it for that particular experience and letting them know that that's just part of what this baby is going through, and that these treatments and supports are going to help that baby through that. And then loose stools is something that's also pretty common for babies who have NOWS. Treatments and support. So all,
Raeanne?
yeah.
Hi. I was just going to add for that last slide. Bernice Byron put in here that often parents to NAS newborns think their baby's cold when they're experiencing those withdrawal symptoms. Parents often describe it as shivering. So just wanted to add that in there before we moved on to the next part. Thank you.
Mhm. Thanks for that. Appreciate it. Okay, so treatment and supports. Again, I'm not a clinician, and there's lots and lots of resources out there already on the clinical side, but just to have enough information to be able to support the families that we work for and to provide that guidance and support for them. There are going to be lots of screening and observation and clinical tests happening for the newborn baby, starting right away and then lasting for several days. The average hospital stay could be 7 or more days for someone who's undergoing treatment for NOWS. The typical stay for somebody who's had a non-complicated delivery could be like as early as 24 hours to 48 hours. And with a C-section, that could be like, a little bit longer if there have been any complications with that. But typically, families are going to need to know that they're going to be, that their infant is going to be admitted. Now, because of the specialized programming that we have dedicated to women who are in a Medicaid assisted treatment plan, and for infants who are part of a NOWS treatment plan or an NAS treatment plan, it should be that there isn't a compulsory separation of the parent from their infant. And there have been a lot of advocacy efforts and work done to ensure that families can stay together for the duration of that stay. NICU transfers are no longer compulsory. They're done case by case. So it used to be that any infant with an opiate exposure would have to go straight to the NICU. For a lot of our families, that means they would have to be flown out or taken by ambulance, sometimes up to many hours away, as you know. For people in a big city, that means that they could even have to go, down the road to a different facility. but it isn't compulsory anymore. But that doesn't mean that it doesn't still happen or that babies still don't need NICU care. They could still. It's not mandated automatically. So case by case, there could be a transfer to NICU, but it could be that the care is able to be done right there in the birthing facility, and that families can stay with their child. Babies can definitely be receiving medication management, and our resident nurses in the chat can let everyone know what that's going to be. But typically, there would be withdrawal support provided to the actual infant if needed to assist them through that withdrawal experience and to reduce the severity of those symptoms that we talked about. It's not like the amount that's needed and for how long. Again, that's just going to depend on the baby. Discharge is dependent on a couple of different things. One, they're going to be looking for a reduction in symptoms. Some of those symptoms can last for like up to a month, and so they don't need to stay that long. But what they're looking for is just a reduction in those symptoms and an improvement in the overall well being of the child, including a healthy weight gain and success in feeding. And we'll talk about feeding support on the next slide. And just for every family to know that there is going to be case management that's pretty much going to happen for 100% of the families who have an opiate exposure in the perinatal period. And that doesn't always have to be like we're policing families and we're creating, a sense of being threatened by CPS. We really want to work to make that experience more supportive to the family. So, talking it through, letting them know what to expect with case management, and having caseworkers in our community who are familiar with the cultural and communication needs of Native American families is going to be really, really important. I've definitely worked with families where even though case management is already happening, someone on the floor would call CPS on them for having a substance exposure. So we need universal training and policies across all facilities where every person who works on the floor knows that it's not necessary to call CPS for that reason alone, and that if there's already case management going on, we don't need to add in extra visits, surprise visits from CPS, because that can be really traumatic to a family. And it can really shake their confidence in the support systems around them. I've had families who are already undergoing case management, who are in a recovery treatment plan, whose babies were experiencing NOWs because of the Medicaid assisted treatment plan, not because of illicit street drug use, um, who have had CPS called on them by someone on the floor. And they don't tell you who it is, and they don't tell you they're doing it, of course, and who have had in the middle of the night people showing up on their door. And it can be really scary for them, and it can really piss them off, and it can really shake the trust, because now they're looking around like, who on this shift called me in. And it can just really diminish the trust that they have, which is something that we worked so hard to um, provide for the families. So we just want to be really transparent about the case management services that a family is going to be able to access and what that's going to look like for them. So there's definitely some systemic issues that can be had with that. Okay, so postpartum supports and early parenting supports. Rooming in is supposed to be standard for all of the families, even if their baby has NAS or NOWs. Rooming in meaning that the infant is able to have their bed brought into the room. It could be like in some facilities, they're moved to a postpartum recovery room. So there could be some moving down the hallway that has to happen. In some facilities, you stay in the same room. It's just really dependent on where you're at. But the baby should be able to stay right there. And all of the screening, all the testing, all of the observation, all of the medication management for that baby should be able to be done right in the room. And if there's any reason why an infant has to be taken out to the nursery or for other types of testing, then a parent or support person should be able to accompany them so that someone's always there with the baby. It, it's really good for parents to know this, for all parents to know this, and to know what their rights are and what the typical practices are of the facility. It used to be such a problem when I started, you know, working for families as a doula like 15 years ago, because literally they would take the babies out of the room and they would take them down to the nursery. And I would walk down there and see them giving a baby formula who's specifically supposed to be breastfed without the consent of the parents. And we've heard all the horror stories about the medical testing and the drug testing and non-consensual things that have been done to American Indian infants without the knowledge of the parents. So it's a little different now. Strides have been made since then, where babies are supposed to be under the care of a trusted support person or parent at all times, and that nursery care is done in a much more transparent way. But the standard is rooming in for all babies nowadays, including those who are undergoing treatment for NOWs. That could be something to think about if a family is struggling with some of the symptoms, especially the high pitched crying or the lack of sleep. It could be that they want their baby to go down to the nursery and that they just need a break because that constant exposure to that fight or flight sort of feeling is going to really deteriorate their mental health. And so that's just some guidance for them to know that they do have that ability and that the baby can be brought in afterwards. But it's not no longer standard that we take babies and we put them on the other side and you can wave to them through the window like we see on TV. Now, every baby with NOWs is a little different. And so you'll see like advice for supporting parents. They need to know that they can try different things. Some babies are going to really respond very well to swaddling, especially if they have really tight muscles or if they're shaking. They just can feel really soothed by the squeezing of a swaddle, including our traditional swaddling practices and our cradle board practices. Other babies will absolutely hate it. They don't want to be constrained or constricted. That's not going to feel good to them. It's going to increase their distress. And if that's the case, it's okay. We don't want to moralize early parenting practices. So we say things like swaddling's really great. It's really healthy. Babies love it. And then, or cradle boards are, traditional. And then when babies don't like the cradle board or they don't like to be swaddled, parents feel guilty, like they're doing something wrong or they're not, Anishinaabe enough. So I try not to moralize like what's right for each baby is just right for them. And so if a baby doesn't respond to swaddling, we can try something different. Some babies respond really well to skin, and you can't do skin to skin if you're swaddling. So skin to skin is like a baby that is undressed or just in a diaper, and the blanket's going to be on top of them, but they're going to be on the bare chest and or belly of a supportive, sober, awake caregiver. Uh, a lot of times it's going to be the gestational parent or the postpartum person. And they're going to be belly to belly or chest to chest with them, right on top of them. So that's what skin to skin means. Uh, some babies undergoing supports for NOWs may not like that because they may feel like they're too out there and they actually want that tightness and the swaddling. So again, we don't want parents feeling bad that skin to skin didn't work for them or that their baby just didn't like it. or didn't respond to it well and increased their distress, it's like, it's okay. We tried it, and now let's see if swallowing is something that can be more supportive. And babies can still be held and talked to, and we can still do a lot of these early parenting skills in both ways. We can do it with swaddling, and we can do it with skin to skin. For people in recovery who are on medications for MAT, and if their infant is going through now symptoms, they are still allowed and encouraged to breastfeed. There's a ton of misinformation about this. I hear something different with every family that I ever work with. Even though I live in one town and we have one hospital, I still just hear like different things from people. So, but the standard is that breastfeeding is allowed and encouraged. It's not illegal. There's the safety of those medications is proven for breastfeeding families through the research and through the evidence. So the standard protocol should be in supportive for breastfeeding, meaning breastfeeding straight from the body, starting at birth and lasting as long as the family would like, and or if there's any sort of treatment where the baby's here and the mom's here, that milk expression should be supported. Formula is not the number one treatment for the baby. Breast milk is. So it should be encouraged and should be supported. There could be some special accommodations that need to be made for an infant going through now symptoms because they're, the crying or the tremors, or maybe there's some observation that's happening for a baby, or if there's a transfer to the nursery or to the NICU. That's when we would come in with some of that support for milk expression, and families still have the right to decide how their baby is fed. There could be other accommodations that could be made as well. So, working with an experienced lactation supporter can be really helpful to a family. Um, and they can try, there's nothing stopping them from trying to breastfeed straight from the body right away at birth. In fact, establishing it within that first 24 hours is going to be really, really powerful in supporting them for that long-term success, especially because some of those symptoms are going to set in after that 24-hour mark. If we already have established several feedings through that first day of life, then that's just going to increase the confidence of the caregiver. Um, Breastfeeding actually is one of the treatments for nows. And so we should really be promoting it because it decreases the severity of the symptoms, improves the confidence of the parent, and it also can and decrease the duration of their hospital stay. And they are still able to undergo medication management for both the infant and for the pregnant or breastfeeding person. So it isn't forbidden, like it's not, the medications that they're on do cross a little bit into the milk. Um, but the benefit of it is so much higher than the risk of that exposure. And it actually is the exposure to the milk that's supporting the baby through now. So breastfeeding really is a medicine for that whole entire family. We can make some accommodations in this space for low lights, less noise, and few visitors, meaning anything that's coming in to disrupt the family is just going to be really irritating. One, because they're already having a baby with special extra needs, and they're already going to be like on edge from the different kinds of crying from that baby, the shaking that they're seeing. The yawning and the sneezing, it's just a very different kind of newborn experience for them. So the less um, visitors and the more support they have, that is what's going to be helpful for them. So we can close windows. We can, um, we don't want little kids in there visiting on their iPad and then their noisy iPads going. It's very tricky sometimes in our community because in a lot of our families really prioritize visiting. And this is a conversation that I always like to have when I'm working with clients ahead of time. So there's no hurt feelings and there's no surprises. But that communication and advocacy really starts prenatally so that they can let their families know that there's going to be no or limited visitors, or that they can designate support persons that could include their family, but for more specific purposes, such as designating someone to bring in food from home, or designating someone to bring in a sibling for a visit every day so you can have that time with them, but that you can still preserve your sleep as much as possible in that hospital setting. So it can be a little tricky with the dynamics in our community sometimes, but most of the time people can be compassionate about it, and we can always engage the help of the staff on the floor to just say that we have limited visitors due to the medical needs of the baby if needed. Okay, so soothing skills for parents. As someone who has worked with lots and lots of people over the years, I've learned to just not assume anything about anyone and to not judge or stigmatize what people know and what they bring in terms of knowledge and experience to their parenting, because everyone is just so different and not everyone has grown up around children. Not everyone has held a baby before or knows what to do with them. And so, prenatally, it's good for those of you who work with families prenatally to introduce some of these skills to them so that they can have some muscle memory and some confidence to do so once their baby's been born. Because that hands on muscle memory to care for a baby in that material way could be very new information to some people. There are some who everything's very second nature to them. They just automatically know what to do, and or they've had experience with children before. So it could be a little bit a mixture of both. But holding the baby, wearing the baby, and then providing those rhythmic movements and sounds is something that can be very supportive to all infants, but can be even more important when you have a baby going through nows, because anything that is soothing to the nervous system is going to be supportive to the experience that they're going. Because an opiate exposure in utero is something that impacts the central nervous system and the digestive system. So that's where you're getting that muscle tone and that the crying and the shaking. So anything that is that bilateral movement that crosses the spine of the baby is going to be soothing to them. And we have a lot of these cultural supports built into the care already. So we can support families to um, practice holding their baby. I like to do this prenatally. It'll bring in my doll, because I work with people in different tribal nations. I have one that doesn't have a face on it because that's a teaching in some communities. And we actually go through um, wrapping baby, holding baby, actually holding them, patting their back, rocking with them, and then introducing some of those soothing skills, such as the singing, the rhythmic shushing, even having our cultural supports, such as a hand drum that's being drummed very lightly, or our rattles that are being that give our voice a break, but still provide that rhythmic sound that can be very soothing to the nervous system of that baby. It is also very soothing to the nervous system of the caregiver. So it's a win-win situation. And once they're back home, some of those symptoms could persist for a few weeks, even after discharge. So that rocking, from side to side, with, from foot to foot, rocking in a rocking chair, patting the baby. Those are all some skills that we can support families to try out and see what works for different babies and what feels the most soothing and authentic to them. It could be you find that one thing, and that's the thing that the baby stops crying and listens to, or that gives them that minute to settle into sleep and actually keeps them asleep. So we just want to be supportive for families to try out different things. And again, no assumptions that someone knows automatically how to do that. That's definitely something we can just teach, and it's okay to do that. Some parents have skills for singing. If singing is not their thing, or if they're feeling shy about it and they're not yet confident to sing to their baby, they could try reading to baby. They can just talk to baby. Some of our Anishinaabe families may prioritize speaking to baby in the language. So there's no wrong way to do it. We just want those gentle rhythmic movements, and we want the rhythmic sounds that can soothe the nervous system of that baby. That's going to help support them through that. And once those symptoms are gone, and once the severity decreases, then they'll have those skills remaining. And it might feel like a huge weight has been lifted because now these symptoms have decreased and they have the skills they need to continue parenting this child. It could be that then getting them to sleep feels easier to accomplish, or that singing to them or doing rattle songs with them feels easier to accomplish. So you can really improve the confidence of a parent, or a family group, by introducing these skills prenatally and then giving them space to try it out and practice it after baby has been born. Okay, so I started with the clinical piece and then get into the cultural piece, which is a little different than how we usually have been doing it, but it felt authentic for this because there's just so much new information to share about nows, that a lot of us are still learning as we go. So I wanted to start there and then get into the cultural piece, but I wanted to bring in, just some stories around our babies and what I've learned. And of course, it's just me. So I just hold what I hold and I share what I share. Of course, I'm just one little person doing the work, and there's lots of really fantastic people who have these stories and who can contribute to and add to the knowledge that you have on these topics. So, this definitely isn't the most comprehensive and only one and true right way to perceive of Anishinaabe cultural knowledge about birth and postpartum. But it's just a piece of that, and I hope it resonates with you. So we have, built already upon our stories around ceremony and what that is, what are our community roles and responsibilities in ceremony, what does it mean to actually birth, and what does it mean crossing into that space and coming back. We talked extensively last time about postpartum and the gentle landing that we're supporting somebody who's gone through ceremony. We talked about those traditional foods. But what about the baby? Because we believe in our culture that babies are born fully sentient and fully conscious. And we have the belief that many of the Anishinaabe babies who are born to our people in this place and time are are have been or are capable of returning from the sky world multiple times. We have a lot of teaching that feels a little um, I feel a little more protective of those in an online setting, but I'm always happy to share them in real life with anyone who wants to know. But basically, we believe that that like the spirit of that person, not only is like fully intact when they're born, um, but is like a mature spirit inside an immature little vessel. So I've heard people say it in really different ways and in really funny ways. I will never forget. It was a long time ago, but I heard this speaker at a conference, and she was talking about our babies, and she was talking from like a cultural perspective. And she said that our babies are conscious and they're fully sentient, like their spirit's fully intact when they come here. Their bodies are like squishy and weird, right? Because they're babies. And human babies are different than other types of mammals. Other types of mammals, like they are born like a horse or a deer, and they like get up and start walking right away. And they start nursing right away. And they can run from danger. Um, but we're not like that. Human babies are carrying babies, meaning they can't move on their own. They literally have to be held and carried to survive by a trusted, safe, sober, awake caregiver. And On the way this speaker was describing it, she said, our babies are not like little sacks of potatoes. Because sometimes we treat them like they are, or like we come into parenting not really knowing what to expect from a baby. And we just think we're going to like toss them over our shoulder or toss them in the car seat like a sack of potatoes. She's like, they're not really sack of potatoes. They're more like brown and serve rolls. And everyone laughed, but it was actually really impactful for me. And I've held on to that phrase for my whole career because it made so much sense, not only biologically from that physiologic standpoint, that human babies aren't done yet. Like they're born more prematurely than other mammals are. And so she said, it's like you take them out of the package, but they still need to brown in the oven. So we can see the baby as being fully alive and fully awake, but needing biologically and culturally the support of a caregiver and the community, the safe environment around them to survive, to continue growing outside of the womb. And so that oven, if you will, to give that baby the safe place to brown up is like you, like it's the body of you, the parent, and the caregiver. It is the safe environment that we as a community provide to that family to surround them with the supports that they need to thrive during that time. Because if we still lived communally, as Anishinaabe, we faced weather patterns, we had wild animals, maybe warring tribal nations. Like we had to ensure that nothing could reach a newborn family so that our people could continue to survive through everything that we've gone through. Uh, we don't think of it that way now because many of us, or a lot of us, have the privileges of being housed. We don't think like a weather storm could take us out or that like an animal could come through and threaten our lives. But the nervous system of a baby still thinks that way. And the nervous system of a postpartum person who's just given birth still thinks that way because our bodies haven't changed. Just the environment around us has changed. So it's really all about this care and safekeeping of the mother and baby as a unit that can be provided solely by them. It isn't really possible for one person to give a baby everything they need to be safe. It is a responsibility of all of us to ensure that safekeeping so that spirit can continue to thrive inside that vessel that's still growing and developing. And physiologically, there's a lot of evidence to support this cultural value to show that newborn reflexes and the survival mechanisms that are innate within them are supportive of life. They are supportive of finding their way to the breast to receive milk. And their nervous system is actually developing in real time along with the nervous system of the postpartum individual. And I've heard in other tribal cultures, I've heard them say it like the baby and the mother are the same person, like physiologically and a nervous system cellular level, and in that spiritual space, it's like they are the same person for several weeks to several months. Up to 4 to 6 months until they have that mature development, where then they start to see themselves as an outside being. And I remember trying to pay attention to this and also feel it when my children were born. And in my third baby, I could really feel that. Like I could tell, like I literally woke up and felt like, okay, she's a different person now. Like she's her own baby and we're not the same anymore. It was kind of a sad feeling, to be honest, to be aware of that. But it was also a little bit freeing. So there is this like essential closeness that we're supposed to be facilitating for all babies and their caregivers so that they can develop appropriately and they can follow our cultural beliefs, that spirit is intact and fully conscious, but held within this sort of developing or underdeveloped vessel. And so if you can take away anything Take that. It's our babies are not sacks of potatoes. They are brown and serve rolls. And they need that protection in order to continue to develop appropriately. And so that's what's happening when we're welcoming these baby down from the sky world. And we have a lot of, spiritual teaching to go along with that. But I just wanted to highlight that as sort of a foundation for us to understand what's happening to the newborn baby at that time.
Rayanne, we have
Yeah.
someone adding some stuff in the chat. So Patrick said, the mama baby dyad is an organism in itself, in and of itself, and must be protected. And it says 40 days postpartum in many cultures. So,
Mhm. Yeah, absolutely, definitely. And I thanks for that, Patrick. And I've tried to ask around, like obviously for so many years I've been asking like anyone I could possibly think of if Anishinaabe had like a particular number, like 40. Like in a lot of intact indigenous cultures, they've maintained this number 32, 40, 42. And every single Anishinaabe person I've ever asked has been like, yeah, but not really. You know how Anishinaabes are always like, yeah, but like, no, it's like a little different for each person. So it's kind of like around 40 days. Could be a little longer. We don't always think of things like in such a numerical way in our culture, or maybe just like we've forgotten it. But we can definitely borrow from other cultures where, like, for approximately 30 to 40 days, there's this really immediate need to provide a lot of specific care and protection to them. So appreciate you saying that. Okay, and this is just this is like the ending for you. This is like the little, glimmer in your brain to think about for the rest of the day. But it is this. It is our belief and our teaching in our culture that because this is a spiritual being that has graced us with its presence, it is a spirit that chose to be here for whatever reason that is, between them and their ancestors, between them and creator. They've chosen to be here. Okay, that any spirit chooses to come to earth is a huge victory for all Anishinaabe people. So it's a big responsibility for us to receive them in this side, and it's our responsibility to guide them through life. And through each phase of life, our responsibility to keep them safe and provide that space for them to go through those rites of passage, starting immediately with their birth. And it is also our belief that when we come here, this is a brand new experience. Even if you believe, like we have in our culture, a belief that we can come back and come back and come back, every experience is new. And so we're learning how to be, and we're learning how to be human. We're learning how to be Anishinaabe. We're learning what it means to be a person in this planet. And so we start that observational learning from the moment we open our eyes as newborn babies. The inputs in our environment are going to shape who we are from the moment of birth. So, this highlights for us the seriousness of how we should be cultivating and curating experiences for people that are safe and supportive and culturally relevant. Because we take so seriously the responsibility of bringing a baby here and of being the ones to receive them. So when our babies open their eyes, what do we want them to see is the first thing they'll see? Do we want babies to see families who are having CPS and the police called on them? Do we want tons of chaos in the room? Do we want them being taken out of the room? Do we want lots of noise in the environment? Do we want stigmatization and shaming of the family, even though they're here asking for our help and support? Do we want, real harsh vibes in the space for a baby to open their eyes and to see? What does that teach them about their choice to come here? It teaches them this isn't safe. Maybe it was a mistake to choose to come here. This world is really chaotic, right? Compared to the sky world, which is just perfection and light. Or do we want babies to open their eyes to see warmth and care and support? Do we want to see the gentle, caring, and loving treatment of their mother? The first teaching they're going to get about how to treat women is the treatment of their mother in birth. So, do we want to see their mom being hand fed wild rice or corn or those traditional foods that we talked about by somebody who's, singing to her and brushing her hair? Do we want families that are surrounded by case management systems that are supportive and non stigmatizing, that are trusting, and really providing that love and care that every family deserves? Because that's what they're going to take in as the first input from their environment, that it is safe to be here. It was a good choice to be here. That even though the parents they chose are undergoing this hardship in life from this addiction recovery, that it is still a good place to be. And that being human is actually really fantastic. And we want all of our babies to be proud to have been born into our Anishinaabe communities. So that's what I'm always working for. And that's why I don't give up on this work, even though everything changes so slowly and progress is so far away, it feels like sometimes, and we're still fighting behind the scenes for the dignity of the families who come into these systems. It's because we care about the family and because we want these babies to feel good and safe that they're here. And so that's really the goal for my work and probably for everyone of you as well. And then the placentas, which is the last thing that I'll share. A lot of people would want to know, same as breastfeeding. Sometimes they kind of see it like the breast milk is like contaminated. It isn't. The placenta isn't either. So, placenta, every single family has the right to bring that home. It doesn't matter if there's been a substance exposure or if there's a positive drug screen. It's still within the right of the family to bring that home if they want to. And there are the protocols that you can ask around to find out what is done with it and why do we bring it home and how to bury that placenta once you get it home and why do we even do that. Um, but it is their right to do so, even if there is a drug screen or a prescription opiate. How to bring it home. All right, this is again another thing that I don't ever assume. We're always like, bring home your placenta and then bury it. But we don't always provide the like, how do you actually do that? Like, what does it actually look like? And some people need a little bit more guidance on how to do that. So typically, they will put the placenta in the hospital after the birth. Often they're supposed to be inspecting it for completeness to make sure that it's whole and intact and there's not any pieces of the placenta that have retained inside the body of the birthing person, because that could be a life-threatening emergency. It needs to be managed in the hospital. Um, and they can even show it to you and you can look at it so you can like see the different parts of it. It's super cool if you're nerdy about that kind of stuff. And then whatever length of the umbilical cord that is cut after the baby is born will stay with it, and they'll put it all into like a Tupperware. It literally looks like an ice cream bucket or something, and I'll have a lid that just closes down, and it can put it in the fridge in the room, or someone can come and take it at some point in the next few hours. It's not going to start deteriorating before your eyes or anything like that. So you have some time. It's not emergent that it has to go in the ground right now or that it has to go in the freezer like right this minute. They can kind of relax about it a little bit. It's going to be in that container. You can go ahead and take it home. Often, if I'm with a family in the birth, I'm happy to just drop it off at home or drop it off with a family member. It's in a container. I'm not weirded out by it or anything. Or we'll delegate, is that a word? We'll designate a family member to be the one in charge of doing that. Often it could be the non-gestational parent, the father of the baby, or another support person, such as a parent um, of the parent, the grandparent or the auntie, who can take that home, or an elder who knows what to do with that. And you can follow those burial customs. It is acceptable to do that even for somebody who's in recovery, for somebody who's been in um, who's been exposed to any substances. They can follow the protocols of the person helping them to just keep it, keep it in an appropriate space. But placenta burials available to anybody, even if they were to have a positive drug screen. I've worked with families where they've wanted to not have plastic involved. And I've had families who would bring in their own container, a plastic-free container, including a copper container, to hold the placenta, just so there's not any exposure to plastics. That had been really important to them, and they didn't want any exposure to cold as well. So just had like a copper container. They put the placenta in there, and then when they were able to get out to go and do their placenta ceremony, they just took it straight from there. If there's any issues with a placenta, know that there are rights that are intact for every single family. It is more normalized now, especially for communities that serve Indigenous populations, that it's more well known that a lot of Native families would like to bring their placenta home because we have our burial customs around it. So I'm not seeing a ton of problems anymore around that issue, but if there ever was an issue, you could, use your advocacy and communication skills to just say, this is why, we bring it home because it's part of our religious freedoms. Use those words, religious freedom, as part of our cultural practices to bring it home. It does belong to the birthing person. Like it is part of their body. And so no one else has the right to take it out. Sometimes they'll tell you, oh, it's policy. We have to do this. If it's important to the family, they can choose not to consent to have it be removed for any reason. Some people, they don't care. They're like, they want to do the testing because they want to know what's happening. It's totally their right. But it's the right and consent of the person. Okay. I haven't had to ever personally deal with that, but I still hear it. I still hear that it does sometimes happen to our people. Okay, so we're right at the end. I thought, oh, we're going to blow through this real quickly. But then I had a lot to share, and we had some good contributions from the audience as well. So we'll do, as usual, our reflection activity, and I'll stop the recording here so that you all can go do the reflection. And then if you're watching this on the recording, that you can do it in your journal.